Okay. I'm pretty sure that means that we're actually live. So hi, everybody.
Hello.
I wanted to welcome everybody out there in YouTube land. And tonight we have a really fun opportunity of discussion. One moment. It seems like I can hear myself on both sides. One moment, everybody. There we go. Okay, thank you again. We'll start over. So, hi everyone, welcome. My name is Dina Chan and I am the head of the Aneurysm and AVM Foundation. Tonight, because we've been all Zooming for so long and we know how to do it, we're actually going to be welcoming some amazing guests from the East Coast. So for those of us that are here in California and probably still working, we hope you will tune in later. Tonight we have an amazing lineup of people to chat, and most importantly we have a guest of honor, and that would be Dawn. What I'd like to do is ask everyone to please introduce yourselves. Tell us who you are, maybe what you do or which facility you're from, which hospital, etc. And then I'll take back over and we'll dig right in. Dawn, why don't you start?
Hello, everyone. My name is Dawn Mureddu. I work for Rhode Island Housing. So we are a company that gets grants and programs for people with hardships. We also have loans for first-time home buyers. So it's a great place to work. I have a lot of friends there, and I've been there for almost 14 years. And I am very happy I'm here today.
And can you tell us before we move on, what specific to our topic tonight is related to you?
So I am the guest of honor talking about the situation that I went through, which was a very large aneurysm, and my recovery and assumptions about recovery as well.
Thank you. I wanted to make sure that everyone knew that you were a brain aneurysm survivor.
I am.
And next is Miss Jenna.
Hi.
Hi.
My name is Jenna Muri-Rosenthal. I'm a speech pathologist and I'm an inpatient clinician at Mass General Hospital now. But I had the pleasure of being the treating clinician when Dawn was in inpatient rehabilitation at Spalding Hospital. I'm a brain injury specialist and I do, cognitive and communicative rehabilitation. Also the founder of a program called Fit to Function Recovery, which I can talk a bit more about later. But I sort of blend functional fitness and with cognitive communicative rehabilitation and sort of bring folks into the gym to kind of further and better their functional recovery after suffering any type of brain injury.
Nice to meet you officially. And last but definitely not least, our friend, Mr. Ogilvy. Dr. Ogilvy, hi.
How are you? Thanks very much. And thanks for the invitation to be on this. I am Christopher Ogilvy, Director of Endovascular and Operative Neurovascular Surgery at Beth Israel Deaconess Medical Center, Brain Aneurysm Institute. I'm a professor of neurosurgery at Harvard Medical School. I had the pleasure of working with Dawn and her family when she went through this process. I am particularly appreciative that you are hosting an event specifically about recovery, because as we get into this, and Dawn had the situation where she had time to anticipate, time to think, time to know ahead of time what was coming, at least try to know what was coming. And you'll, I think, hear that that's very different for very many people, different for different people.
Yeah,
but
definitely.
The other way we meet people is after a hemorrhage, of course, where they don't have time to prepare. And then it's all about recovery. In other words, they don't have any time to anticipate. So a little bit different situations, but appreciative this is going on, because when we talk about this before treatment, there's a lot that goes into it, and there's a great range of recovery and a great range of procedures. I do both open surgeries. I've done over 4,200 aneurysm surgeries, and I've done over 1,200 endovascular procedures, and each has their own type of recovery, phase of recovery, and it's different for different people depending on their pre-existing conditions and then their aneurysm and how they go through it. So we're very appreciative to be here.
Well, I'm really glad that you're all here too. And well, we've kind of hinted at it, and now I think we should specifically say it. This talk is about the assumptions that everyone here has made about aneurysms, brain aneurysms specifically, and the recovery. It's about the word recovery and what assumptions might be made there. I was sharing before we came on that I actually wanted to discuss all of the word recovery. But when I was addressing some folks that I wanted their opinions about, one of them actually specifically said, oh, so you're just going to talk about all of the physical things that happen. I'm like, oh boy, if it was only the physical things that happen. And we will talk about one of my ultimate grand community pet peeves when it comes to assumptions. But what I wanted to say before we get fully into this is that one of the things that our community suffers from, and I mean by community, all of us, whether it's the survivors, the patients, the clinicians, the caregivers, and our families and friends, is massive amounts of assumptions, things they think they know, or they've done the research by going to Dr. Google, or just so many things that we really don't know. And it's, when you're raising children, what do we say? We're ignorant of most things, right? It's okay to not know something. And yet there are a lot of assumptions that persist. When we started having this conversation here at TAAF, we decided that what we would do is we would start an online magazine where we would literally ask one question that everybody asks, either on the clinician side, on the caregiver side, or on the survivor side, but those three are never in the same place at the same time. And those we called TAAF Talks. And so when I was talking about this idea with Dawn, I approached her to write for our online magazine. She did. It was outstanding, but we never stopped talking. And that's really how this conversation began. And I was hoping, Dawn, maybe you could, would you mind giving us kind of that background story and let us into your world a little bit about how you found out about your brain aneurysm and really what happened?
Yes, I will. And thank you so much, Dina, for asking me to talk about this. And I hope maybe that I can help someone, because you never know who's listening. And thank you to TAAF and the Aneurysm and AVM Foundation for having me speak today. And thank you to my wonderful, fantastic surgeon, Dr. Christopher Ogilvy, and my wonderful, fantastic, awesome speech therapist, Jenna Muri-Rosenthal, for being here to talk about how you both have helped me through my journey to get better, to live and recover the best that I could. So I just wanted to go over a couple of, a little bit about what happened to me. So I had migraines for 23 years, and I had 12 to 18 per month. I lived in 3 different states, and I had a neurologist in each of those states. And no one ever looked or even suggested to look in my head. If they did, they may have noticed that I had a brain aneurysm, and maybe that was the reason why I was in pain a lot. One day I was working out. I hadn't in many months because I was working many, many hours at a new position that I had taken. The first machine that I used, I felt a huge pain in the back of my head. And I put my hand on it. I said, oh, I've never felt that before, because it was a different pain. I always had, most of the time, my headaches were on the left side of my head. And this one was in the back, and it was a constant hard pressure that I felt. Very soon after that, I got sick. And then about 2 hours later, I started seeing double. Did I know the symptoms of an aneurysm? No, I did not. I blew it off. About, I think a week or so later, I talked to someone who knew that I had this problem and said, did you call your doctor yet? And I said, oh no, I've had headaches for a week before. It's, it's just, no problem. And so I promised that I would call my doctor. So I did. And my neurologist told me that he was concerned because I said that I can't massage it. And he said, that makes me concerned because I feel like maybe it's under the skull. So you should get an MRI. So I made an appointment. I had to wait another week or so. And they didn't let me leave until I called my doctor. So he told me, you need to go home, get your husband, and get to the ER at the hospital. And so I did that. And when I got there, they looked at me, they did a test of some sort. Anyway, I can't even remember that. And they pulled Chuck aside and they told him that I had a very rare aneurysm. So they admitted me into the hospital, and the nurse ended up telling me that the only doctor in the hospital that would work on me was in the airport going on vacation. So they had been texting him back and forth. So later that night, I had an angiogram, and they kept me overnight. During that time, instead of sleeping, Chuck got on the computer and he was researching, and he wanted to see, what is a brain aneurysm? What is it like? What doctors were in the area? What hospitals were the best type for this type of surgery that I would need? So he found another doctor, one that started the Brain Aneurysm Foundation, and he was right in Boston, an hour away. So we thought, oh, if we need a second opinion, we'll go to this guy, right? So actually, I ended up seeing the first doctor after I visited with Dr. Ogilvy because he had been on vacation. So he told me that I know who you went to see. You've been dealt a bad hand, and I really think you should go to him. So I'm so thankful that Chuck found Dr. Ogilvy. I met him. He told me I needed to have surgery. And he is someone I am so grateful for, because what Dr. Ogilvy did in those long hours of surgery, I don't know all of that. I was out. But I know, my family was waiting there for like 10 hours or however long it was. And I know it was really hard for them. But I just know that I lived through it because of him and his team. I'm so honored that we have him as a guest speaker today. And he will talk about my situation, I'm sure, about brain aneurysms and discuss my treatment. So I just want to say thank you as well.
Thank you, Dawn. So I have a question for you before we move on. From the moment that you had that first headache to the time that you and Chris met in an operating studio, how many days was that?
Well, when I know that it was, I believe, 3.5 weeks by the time I had the MRI in Rhode Island.
Wow.
Then I went to see him. And then when he scheduled the surgery, it was like 4 more weeks away. So, and I was really scared because they kept saying it was rare. And so, but, and I'm sure he'll talk about this, but I think what he said was because that pain that I felt, it was bleeding, and it had stopped bleeding after that. And what he said was, once it bleeds, the chances of it re-bleeding are minimal. And I think I'm right. I hope I am. So he can tell you if I am or not. Hey, you know, I don't remember everything anymore. So what the heck?
Oh, I have to write everything down, and I didn't go through this.
Yeah.
So, Dr. Ogilvy, it is not in any way rare for patients to have adoration for their outstanding and amazing surgeons. You just happen to be one of, I would say, in my own experience, 5, maybe 4, that are also constantly loved upon. Is that okay to say? But I'm really glad that you're here for so many reasons. And one of them is, how do you feel about telling us Dawn's story,
Sure.
reverse engineered? Can you help
Sure.
us understand it from a clinical side?
Sure, it's a little different. I mean, all aneurysms sometimes are a little like snowflakes. They're all a little different.
Right.
And we think in her situation, actually, she might have had a little hemorrhage initially, but by the time I met her, the risk of re-hemorrhage was back down to pretty low. When an aneurysm bleeds in a more dramatic way, the chance of another hemorrhage is quite high in the next 2 weeks, almost 30%. So we like to get patients right in the hospital and get those aneurysms treated. Dawn had the unusual situation. Her aneurysm was large, which is why when you go to have an MRI scan and the technician comes out and says you need to go to a physician or emergency room, you know it's something pretty obvious. You know, it's something you can put the films up and pretty much show the person sweeping the floor or walking by, hey, look at this. And they'll say, yes, I see it. So Dawn had one of those scans where I could show you those films right now, and it'd be no secret she has an aneurysm or something.
What type of aneurysm did she have?
So the other thing is she had a middle cerebral artery aneurysm. We will obviously name aneurysms by the artery of which they arise. But the complicating features in her aneurysm is that it was partially fusiform, meaning, as you all know, but maybe not everyone listening knows, there are saccular aneurysms, which are a bubble that form where arteries divide. And then there are fusiform aneurysms that can be partially a bubble, but also involve the arteries from which the aneurysm arises, so that they look sometimes a little bit more like a sausage instead of a nice ball you can clip off. And coming from that sausage is one of the important arteries that feeds the brain. So when we looked at her film, she had the angiogram done, and then she went home, and I saw her as an outpatient actually initially. So when you said, how long was it between the time of her headache and the time she met me in the operating theater? Actually, we met in the office and we had her angiogram and we had it to go over. But I knew at that moment, really, this was a more complicated aneurysm. About 20% fall into the type that she had, and it would need a more complicated treatment, meaning a bypass procedure where we actually take an artery and suture it. We take an artery from the outside of the brain and suture it to an artery inside the brain to make a new pathway for blood to get there, not through the aneurysm, but through this healthy vessel, which is on the outside of the head and then sutured to the inside of the head. And that's why it's called a bypass, just like a bypass for cars or for your heart. You know, it's a similar concept. So that's what she was facing. Now, to truly reverse engineer this, when someone walks in the office and sits down, the discussion you have with them can be quite varied, meaning it's based on their age, their what we say comorbidities. Do they have diabetes? Do they have high blood pressure? Thankfully, Dawn is an incredibly healthy individual. And I think before and subsequent to this, she works out regularly. She's in great health. So that definitely works in your favor when you're facing treatment. It also changes the tenor of what a physician thinks in terms of what someone will be able to tolerate for treatment, and also what their recovery might be like. And we're going to talk about recovery, although it's sometimes very difficult to predict. I've had patients who have a history of depression and a history of lots of psychological issues, and I think, man, this recovery is going to be a project, and they sail through it. And other people that for some reason or other, they have no history of any previous problems and they struggle with recovery. And it's sometimes very hard to predict ahead of time who is going to fall into which cell, who's going to fall into which category of recovery. And meanwhile, you're trying to talk to someone ahead of time and explain that to them, and it's tough. So layered on the fact that Dawn had an aneurysm, she also had a complicated aneurysm. However, both she and her husband are highly intelligent individuals, and we could have a very high level discussion about what we would be planning, because they would understand the different steps. And the fact that they're high level individuals doesn't matter so much. I've found that people from all walks of life can often understand a good majority of what they're facing, if it's explained properly, and they can have a good overall understanding of it, and a general idea of risks and benefits. And so that's what the first discussion becomes. Is it riskier to fix this thing or leave it alone? Well, in her situation, it was clearly riskier to leave it alone because of the size, the location, all those features. Her chance of getting into trouble in the next 6 months or a year were significantly higher than the risk of a surgery, although the surgery she underwent was higher risk. Aneurysm surgeries have a range of risk,
Right.
and her risk was in the little bit higher range than someone with a smaller aneurysm in a different location. These are all things that predict risk, and we've done a lot of work looking at outcome from aneurysm surgery and what of those factors are important, because we use that information in decision making of who to recommend treatment for, who to not treat, and how to treat them.
Well, you're actually kind of talking about where we're headed here in part of this discussion, and that's that even those things that you're doing, that kind of pre-gaming, right? You're having these conversations, even those are based on assumptions from really great and amazing research, but still it is an assumption because you're right, there are all of these different factors that go into it. Dawn, I know that one of the assumptions that I hear a lot, and I know we talked about this a bit, was the idea that once you've had brain surgery, right? And we're putting up those air quotes because people have such emotions around those two words being put together for good reason, right? But once you've had brain surgery, everyone kind of assumes everything after that is going to be kind of downhill. You've done the hard part, the actual brain surgery. And yet, as you've already discussed and Dr. Ogilvy just said, nothing could be further from the truth. We don't know really what that's going to look like in recovery. So I'm going to ask you, what were some of your assumptions about your recovery? And after you tell us what some of those assumptions were, I'd love to know, and I know the audience would love to know, which ones turned out to be true and which ones turned out to be false.
There are a couple of assumptions that, for me, one thing was that the left side of my head was where I had the aneurysm. And that's where I always had my headaches. And, I couldn't tip my head upside down on most days. And I just thought it was just me. And because it was so large, and when I saw Dr. Ogilvy, he explained to me that, one of the risks I would have would be to, I might lose my speech. And for me, I thought, how could I lose my speech? I enunciate well. I'm a great speller. So, I had no idea. So I really didn't think I would lose my speech. So the loss of speech, that became true. I woke up, I couldn't walk, I couldn't talk. I couldn't pick out a color. They gave me flashcards. I didn't know what a house was. So it was very difficult for me. I woke up and I felt like I was a 1-year-old. So basically I had to learn everything all over again.
Were you frightened?
And excuse me?
Were you frightened?
I had asked Chuck to tape a lot of it so that I could see myself progress. And in one of them, someone was saying, this is blue, this is yellow, this is red, this is green, pick out green. And I picked out a different color. So in that video, you can see myself kind of go back, and I was really frustrated with myself, but I was very quiet, and I couldn't believe I couldn't get that. So I think I realized, like, why can't I get that? Mm-hmm. So that was tough. But the thing that I realized was that my family wasn't freaked out. And I always ask them, like, how did you not get freaked out, especially when you saw things like that? Because, you know, what's going to happen? And all of the medical professionals told them that this is normal to come out like this, and things would probably get better. And they had faith in the professionals to guide me. And one day I got that flashcard house, and I was so excited that I was like, wow, maybe I'll remember that tomorrow. And I did. And so every day was like, I got a word. And so I think that's when my family realized, oh, it can get better. So I think that's what we were doing. But I assumed Dr. Ogilvy, you know, what do you mean I'm going to lose my speech? And then I woke up, I'm like, oh, I lost everything. What's going on? And also, what did Dr. Ogilvy mean when he said, it might take up to 5 years for your recovery? And I was like, that is a really long time. I mean, wow. But that was true. I did have both cognitive and physical impairments, significant in the beginning and very slight over time, but they were there. And over the, Dr. Ogilvy was absolutely correct. I noticed a change from year to year. And even from year 4 to 5, I noticed that I was remembering more things. I even noticed that I had less fatigue. And we all know fatigue is the biggest one. And even after the 5th year, I did notice my fatigue was better as well. And, you know, and for me, speech was a lot. I said S and CH and SH, and a lot of times those kind of were just all zh, 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 zh. And so when I'm tired on the weekends, you know, I just let it go, whatever comes out. I'm very good during the week, whatever happens on the weekends, we don't care. We laugh. We have a lot of laughs in this house. I'm just going to give you one example. So, you know, I was taught kind of to, you know, describe the word if I can't figure out what the word is. So I was trying to think of something. I said to Chuck, you know, I don't know. It's this guy. He talks a lot. I don't know. He talks a lot, though. It's this guy. And he goes, are you talking about the Speaker of the House? And I go, that's it. So we do have a lot of laughs. So I think that's a lot of it. But yes, the assumptions, you know, he was right. That's all I can say.
I think you're saying a lot. You're also doing a great job of high-fiving Jenna without everyone knowing it yet, but we'll get to that later. Yeah, and you touched on one of my ultimate pet peeves, which we will also get to later. So Dr. Ogilvy, I'm going to ask you the same question, but obviously on the clinical side of it. What assumptions did you make going into the surgery, and obviously specifically about recovery from that surgery? And please, if you don't mind, also tell us which ones turned out to be true and false.
So this is a great question, and we tried to prepare Dawn for the fact that the artery I was talking about that we had to manipulate, that we have to pinch off for 20 or 30 minutes while we sew these arteries together. The brain that is fed by that artery is gonna notice, It's not really a stroke always, but sometimes it can be a small stroke, but it can be the brain is deprived of oxygen and glucose, and it notices that, which is why we were worried that she would wake up with some speech issues, which she had. I think your description is fantastic of this moment where she's able to realize that she was disappointed or didn't get something. So that's a great sign for me in someone's recovery, because what that is frustration, and frustration is expectations not being met.
Right.
And when someone has the insight to realize they're not where they think they can be, that means things are happening. Things are really happening. We have this with people with Alzheimer's and memory trouble, that they'll sit in the office and the family's behind them, and I'll say, do you have any memory, or I won't say, but neurologists will say, do you have any memory issues? And they shake their head and say, no. And the family's sitting behind and say, oh, yes, they do. They have no clue that they don't have memory, that they have memory trouble. But when someone says, I'm really struggling, then I know that they have insight into their problem. They're frustrated. And I think that often helps their rehabilitation process, because they know they're not where they can be. And Dawn is a very driven person and very goal directed. So her realizing that meant, I know where I'm not where I'm going to be. I'm frustrated, and she continued to work to get there, where she is now or beyond. And so that's really a kind of an insightful story to hear.
And it's an assumption that we as the community can now make for ourselves. Now we can start assuming the better part of what that is, because what she's assuming when it's happening is that she's not making enough progress, that she's not doing well, that she's having this frustration because things aren't working. But the reality, and I'm actually having a moment here when you said it, I was like, oh, that's such a great new assumption. We can actually be assuming we're doing well.
Right. Instead of taking it as a disappointment, those little keys, for those days when she didn't have a clue what the color was.
Right.
And all of a sudden she knew the color one day and realized that she knew the color. Not only that she knew it, but that she realized she knew the color. That's when we can say to people, hey, this is encouraging. I realize it stinks you don't know all the colors right now, but the fact that you realized you didn't know them is a very impactful thing. And I always take it as a very encouraging thing to hear. And that's where listening for little cues like that, little parts of the story make a big difference sometimes in someone's rehab. And that's, I also say that, and I said this to Dawn, look, I'd see her at a month and I'd say, look, where you are now is not where you're going to be in 3 months. And I don't say that to discourage you. I say that to encourage you that there's going to be better days ahead. And, lots of recovery is better days, worse days, better weeks, worse weeks. But overall, the graph is up. And so sometimes people say, when you said it a year, that actually made me feel better, because it meant that I'm not plateauing at 6 months and I'm all done. And that it does give people some, hope that things are going to get better. If they're 85% there, they know that there's room to get 95% there. So those are the things that go into it.
Thank you so much for that. Jenna, I mentioned that Dawn had been kind of high-fiving you there, because a lot of the things that she was saying were obviously moments of your instruction. They were, though she'd been hearing certain ways to express herself, or to, not necessarily beat herself up, things like that. I also am keen to have heard ways that she was instructed, or pardon me, her family was instructed to monitor how she was doing as well. And I know that that was also a lot of you. So we'd really love for you to help us walk through the therapy side of things. It's not something that sadly is addressed a lot, whether it's because, golly, none of our patients can get it because we're not paying for it in this country, or if they do get it, they only get 3 sessions with you. There's so many reasons. But I want to welcome you again, remind everybody that we just heard Dawn high five her 1,000 times, let her express to you why that is. And just, Jenna, take it away. Thank you.
Yeah, thanks so much for having me again. And I'm just nodding and smiling along, because things are just so poignant and meaningful. And I feel like like, Chris, we could have been saying the same things as far as insight and recovery. And I'm going, yeah. But so when I met Dawn after, so I don't recall how long you were in the hospital before you came to inpatient rehab, but I met Dawn on her second day in her inpatient rehab stay, which is after you've had your big event in the hospital and you're no longer need immediate acute sort of medical care, you go to another hospital, and that's a rehab hospital. And a lot of folks aren't aware that there's a difference in those things. So you still need the watchful eye of a physician, but you also are ready to start your rehabilitation course. And for most folks, that's physical therapy, occupational therapy, and us, the sort of unknown stepchild there of speech therapy. It's usually OTPT and speech. And so Dawn, because this aneurysm was on the left side of her brain near the language area, she came to us with a pretty severe aphasia. And aphasia is a language a language difficulty caused by an injury to the brain. And I will never forget, I walked into Dawn's room the very first day. So someone else had done her initial evaluation, and then she landed on my caseload. She's going to be my patient. And I come in and she's sitting upright in the chair, and she's got her tray in front of her, and she's got her flashcards and her notebook and her pen. And she's got sort of a smattering of words and partial words and sounds. And I walk in the room and she just starts talking. And most of what she's saying is not real words, but immediately we fall into a rhythm and a routine of where I get your message. Let's talk. Let's start by talking about communication of your message. And so one of the big things in aphasia, right, is there are so many ways for us to communicate a message. And when you have aphasia and that lends itself to word finding difficulties, we talk about it as an access problem. You know what you want to say, but you can't get there. What comes out of your mouth is sometimes totally unrelated. Sometimes it's not a word. Sometimes it's a neighboring word, something that means something similar, or something that sounds similar but doesn't mean the same thing. And one of the things we always encourage our patients is that I don't care what the word is. The goal is to get the message across. So what Dawn was talking about, that strategy where you describe things, we call that circumlocution, because ultimately at the end of the day, if you need the thing on your face that helps you see better, it doesn't matter if you said the word glasses. I know exactly what you mean. The listener can now intuit your message and you're communicating. And so we really started there. We used the flashcards and we say, okay, maybe you can't tell me the word, but what is it? What's it look like? What do you do with it? What's its function? Where do you find it? And you start there, and those are sort of building blocks, right, into better communication, because if you can convey the message, you can have a conversation.
When you walked into the room, and like you said, you didn't do the initial consult, what were your assumptions about Dawn? You knew that she had had brain surgery, right? Did you know what had happened?
I knew, I had done a quick chart review. I saw, she had this large aneurysm, she had a surgery, she has aphasia. I'd read it. I just hadn't put her through the testing myself, which any good clinician honestly loves to do their own testing, because you make your own, you intuit your own sort of treatment plan and what you know about the person. And, much like you were talking about in terms of surgical recovery, similarly, when we sort of prognosticate how we think someone will do, it matters how, what their injury was, what their time in the hospital was, who their surgeon was, how quickly they recovered, how healthy they were, what their family support is like, how active they were. And so going into the room, I know, okay, she works out, she's motivated. And then I walk into the room and there she is sitting at her table by herself, kind of working. And I was like, we've got a good, big prognostic good picture. And Chuck came in later that day, and he was he just sort of like absorbed, what's a speech therapy vibe here? Okay, I'll just help her get a message across. It doesn't matter what the word is.
That's amazing.
Yeah. And, so, and because, in terms of prognostic indicators, and, Dawn was motivated and she wanted to get back to work. And that was one of the first messages that she shared with me. And it was like, okay, what are the things that you need to do to get back to work? And that involved speaking, reading, writing, and numbers. She wanted to work on numbers and she's laughing. And so even though for her, the priority was speaking, we were always going to target the things that were functional and important for her. So we would spend parts of sessions drilling language in a variety of ways. And then we'd play with apps. We'd get on the iPad and we'd do math and computation, because it is all about what's important and functional to the individual as well. So.
One of the main ways that we choose to serve at TAAF is by doing individualized care. And it means everything from start to finish, as you can imagine, with a patient or their family. And it's just, it's always lovely to hear that that's exactly how different clinicians handle their jobs and their relationships with people, because you have to meet them where they're at and what they're wanting to do. And one of the big assumptions, and I actually didn't learn this from Dawn, I learned it by leading our support group, is that, oh, I will go right back to work. I'm a worker bee. I know my job. I'm great at my job. And this is not going to define me. A lot of, I'm going to get right back in there. Now, that could be directly related to the person. Absolutely. It could be related to the fact that as Americans, we define ourselves by what we do. How long are you in a room of brand new strangers before someone says, oh, what do you do? Right. So it could be that. But I'm curious to know, or if we start with that assumption, right, this idea that we all think we're going to go right back to work. It was one of Dawn's biggest goals when you met her. How do you need to soften that expectation? Are there assumptions around that? Because I'm assuming this is kind of my soft landing, Jenna, to say, I know that you went on to be a founder of something amazing that's relatable. So take it from there.
I think, like you said, our identities are very much tied up in our roles in society, and a lot of that for individuals is work. And I think standard rehabilitative care, we have all of our tasks, right? I could hand you all these worksheets and you can just do these things to build your base vocabulary. Sure, that's going to help you get better, but is that going to carry over and be meaningful to you? And so we think about, what do we need to do to get you back to work, and how do we scale that down to where you're at? So, at a very simple level, if you need to name items in your office, we'll start with pictures of things in your office and we'll practice your language around them rather than these pictures in a book. And I think that getting back to work for a lot of folks is a goal, and we do have to soften the blow. I think particularly folks are, as they recover, they want to get back to work right away. And sometimes you can be ready-ish to go back, but not ready to fully succeed. And so often what I will tell individuals that I work with is that better to take the time and let your brain completely recover and go back completely successful than go back too early and fail, because it's hard to undo failure. It's hard to show back up to work, say I'm ready, and not be present cognitively or not have the cognitive endurance, because that's a big piece to kind of last. And so we do talk about that. And I often encourage individuals, and Dawn and I talked about this at length, that taking baby steps, right? For some people, go to work 1 day a week for 4 hours. Or 2 hours, 2 days a week, whatever the case may be, so you can start to get your feet wet and see how it feels. Because everybody in their own mind is like, yeah, I can go to work. And then you ask them to start doing tasks specific to work, and it's a lot for a recovering brain. So yeah, I would say we do have to soften that a little bit and also help lay out a roadmap. And I think part of the struggle with standard rehabilitation is you're sort of like, okay, you're good enough. Okay, go home. What happens next? And how do we help you make that functional leap back to things like work? And that's very much our role as well.
And you started, I always say fit to function. I know it has a longer.
No, that's what it is.
Forgive me. But when you started
fit to function,
was it more to combine those two pieces? Because you're right, there is cognitive exhaustion, and then there is obviously physical exhaustion. And sometimes it's very hard, I think, for those who are in recovery to separate the two.
Yeah. I think part of I started taking on a lot of private clients. People would leave rehab and they'd come back and say, can we keep working together? Insurance is over. I'm no longer in rehab and I'm looking to continue my care. And what I found was really out there in the world is there's not a good bridge from that rehabilitative care back to functional existence in the world in whatever capacity you want that to be. And a lot of folks who can't get back to work are very isolated. They've lost their community, maybe their social community, their work community, and they don't engage in a lot of tasks because they don't know what there is out there. And so one of the things I wanted to do was sort of blend fitness with better functional recovery in the way that you move and the way that you think. And in an environment like a gym, which, it's a CrossFit gym, which CrossFit is very community centered. And so the idea was like, we want to bring you in, help you move a little better, help you talk and think a little bit better, and blend you into this community so that you can have an experience of a recovery or in finding a place that you belong. And from there, balancing not only kind of putting, because, fitness really fits in on that wellness continuum. So we want to make sure that we help you keep improving across everything, the way that you move and the way that you think and your general health and wellness. And also, just help individuals see, okay, there are ways that I can reintegrate into the world. Maybe I can join a gym. Now, maybe I have a social network. Maybe I can find a job. And even if it's not the job that I used to do, I'm out there in the world and I'm existing. And that was sort of the premise of all of it. And it's been a really powerful tool for the folks involved. And I think, Dawn predates my Fit to Function, but we've been in touch all of these years. And I think one of the things that is so powerful in Dawn's recovery is her commitment to her fitness. And that has driven her and helped her with her wellness and her recovery throughout.
Yeah, she and Chuck are aging in reverse.
Yes.
In fact, they're going to have to teach the rest of us how to do it.
Yeah.
Thank you for that. I think that I think what you do is amazing. I just really do. So I talked at the beginning a little bit about why TAAF Talk as a magazine, wanted to gather these perspectives in one place at the same time. And what I'd like to do now is have us unmute ourselves, which I know in Zoom land is not something we do, but I'd like to have more of a roundtable, because I do think that we should, kind of address some of the elephant in the room, and that's that where do these assumptions come from? Whether it's from a community of survivors that maybe are talking to each other, or are there assumptions within, the clinical side, and maybe Dr. Ogilvy, you can talk about other neurosurgeons and how they think perhaps, but generally, where do they come from? Are they good for us? Have they served us well, or what are we doing to combat them? I'm going to start with my first one, my pet peeve. So one of the first things I heard when I was able to take over our support group was someone had said, oh, I was told that at 1 year, that was as good as it's going to get. That was all I was going to be able to do. That was as far as I was going to be able to go, yada, yada. And, being the practical preemie that I was, and again, major layman, I just kind of listened and took it in. But I also came to this or to this community and my organization from a place of loss. So it was stuck in my craw. I didn't like hearing it. I didn't think it was probably correct. This was years ago. And it kind of made me mad. And so I started to ask a lot of questions. And then I just also did a little observing of the people that were in this group. They'd been there before the organization was even formed, some of them. And I talked with them, I interviewed them and asked, how did you feel at first? How did you feel 3 years later, et cetera, et cetera. And what I learned just on my own was that they were making all of these strides every single year. And every year after, they had felt better, different, stronger, et cetera. And so now the more I heard it, the angrier I became until it was not just stuck in my craw, it was the pet peeve. I was going to get all neurosurgeons to stop saying it. And come a couple months after a conversation, I meet Dawn and she says, "Oh, Chris said 5 years." And I almost fell out of my seat. And I said, "I've never heard anyone give a timeline, mind you, that was that far out." So kudos to him at the time. And I know Dawn was like, "Yeah, it was amazing. I was so happy too." But I was also like, "No way, man. That's not going to be me. I'm getting up day one." And that happens a lot, right? Those are assumptions that we have. So I hadn't heard that, Chris, and I'm so happy to say to you that you're one of, again, of 4 people maybe that don't give this 1 year timeline. And so I'm just going to put that one out there as my pet peeve, and I guess I'm picking on you, Chris. Maybe you can help us answer it. Where does it come from?
So I'm happy to pick that up. There's a couple things to mention. First of all, Dawn's aneurysm was particularly difficult from a technical surgical challenge standpoint, which is why we kind of had prepped her ahead of time and why she ended up in rehab. There's a range of this disease. The fellow I operated on Monday went home this morning. He'll be back driving his truck probably in about 2 weeks.
Right.
He is motivated and he is ready. He walked out of here. He was dressed when I went and rounded on him at 6 this morning. So there is a range. And unfortunately, or whatever, lots of people who do really well with this don't go to support groups. And sometimes I tell them you should, because they're like, "Why? I'm fine." So sometimes people who seek out support groups, are needing some extra help. The other thing, it's funny, you were talking about, some of the things you touched upon, and we've thought about this before, the Kubler-Ross stages of grieving actually apply to major medical problems as well. Major medical, you probably know this, but the denial, depression, and then ultimately acceptance. And you don't go through them in a nice orderly fashion. You jump from anger to denial to depression, and sometimes you go back. So that's going on. Now, the timeline of 1 year is an interesting thing because I've heard it a lot from neurologists, neurosurgeons, behavioral folks, and I think it comes from several areas. One, that's what a lot of published studies report. The 1 year result is this. And so that's where the data comes from. However, if you're a clinician and see people, and what I do, and I think this is different, and when I was a resident, it's certainly different than what neurosurgeons used to do, because neurosurgeons are proceduralists or were proceduralists. Now we treat a disease. When I was a resident, they were proceduralists who did a procedure. Once you were done with that, you saw patients once at 6 weeks and you never saw them again. That's
like really amazing mechanics.
That's the way a lot of my mentors ran their practices, and it didn't even scratch the surface of what was really going on. And when we started the Aneurysm Foundation, that was one of the interesting things, is some of the older neurosurgeons in the country said, "Why are you doing that?" And I said, "Well, to get information out there, because there's very little information about this." It was before the internet. There was very little published information that was readable by patients and their families. So we started doing a couple things. We started doing longer term outcome studies. And to do that, we followed our patients for longer intervals. And we started to, so I'd see someone every year for 5 years, as opposed to up to a year, and then you go back to your regular physician. If someone doesn't have any issues and the recovery is going well, following them for 6 months or a year, sometimes it's 6 months, I really don't need to see you. I'm doing great. But if people were struggling, I found it was better to see them for longer intervals. Not only did it help in the recovery process, but it helped us as medical folks learn what the pace of recovery could be. Now, the other thing that can influence that heavily is age. So that for older folks, this timeline of recovery, what someone who's 30 does in 3 months, someone who's 70 might do in a year.
Right.
And it doesn't mean it's not going to happen. It's a longer interval. And it's true for almost every illness. But particularly for aneurysms, which is what I study most and know most about, we see that as a phenomena that definitely age layers into it. And sometimes, getting back to your assumptions of recovery, we layer that into the discussion before treatment that, hey, you're 75, we're going to take you through this process. This recovery might be more like 10, 12, 14 weeks, not 3 to 6 weeks. And what I mean by recovery, I mean recovery back to where you're ready to go back to work or your previous function. And going back to work is a very interesting topic. Jenna touched upon some of the issues. And when you talk to people before surgery about returning to work, some people are already having you fill out their return to work forms for as long in the future as possible. So if someone works for themselves, building houses or for whatever their business is, and they love it, they are back at work. I'm never worried about them being a motivated returner to work. If someone works for the government or the state, hates their job, they want to be out for 6 months, regardless of what's going on. So there's a great range. There's a lot of psychological things built into this. Dawn was a particularly motivated individual. She likes her work. She likes where she works. She helps other people. And all these are very favorable prognostic factors for people returning to work. Jenna touched on a couple of things I like to mention on a regular basis to people, which is returning to work. Don't return to work if you're not ready. And I use the same exact verbiage. That is, we want you to go back when you're ready. We don't want you to go back and fail. Right. Because then, and that it's got some stigma attached to it at work. Oh, gee, he came back to work, he had brain surgery and he didn't really do that well. And we don't want you sitting home bored if you're ready to go back to work. So there's a balance in between, and this part-time return to work, either a few hours a day or a few days a week, depending on what type of job people have, can be extremely helpful. Lots of people, their first times back at work, they go to work they find that just getting up, getting dressed, and getting to their desk, now that people are going back to their desk, they're exhausted. They sit down at 8 in the morning. They go, wow, I'm exhausted. I just got up at 6:30 like I always did. I got dressed. I came to work. They sit at their desk and they kind of close the door because they're like ready to take a nap or something. And then yet over time, that stamina builds. And that stamina building, part of it is just the tincture of time. Part of it's therapies and using those functions. But part of it seems to just be that tincture of time, that just having those days and weeks go by helps to build your stamina back. But it is definitely a process, as you all have touched upon.
I'm so glad to hear you say that those that aren't quote unquote struggling should go to support groups, because it is so important. I think a lot of the times people don't realize how incredibly important they can be, and how just freeing it is to go into something for an hour and a half and not have to be beholden to anybody. Like it's like Vegas, right? Whatever you say stays there. Dawn, can you talk a little bit about some of the assumptions you see in maybe the survivor community and things you'd like to address?
I think that the only other assumption that I really always think of is that when people see you again, they say you look great. And in our survivor community, we all talk about that because people say you look so great.
You look fine.
But the thing is, they can't see my brain, and they don't know how exhausted you are all the time. And the fatigue really gets to you. And so that is the biggest one. Now with, Chuck and I both researched and with recovery and everything. And we kind of made a deal together that beforehand, we shook on it and everything. And we said, I'm going to do whatever they say. And, I'm going to do homework too. If I can handle it, I'm going to do homework. And so, I often thought that, if I lived, what I would be left with, whether it be any physical impairments or anything like that, it's proof that I'm still here. And so, that was a big thing for me. And so when people say, oh, you look great, it's my brain. They can't see my brain. And when I went back to work, I want to mention this quickly. When I went back to work, I did go back a little early. And, I ended up taking a job because they gave my job away because I was out of work for a while. With my aneurysm was so large and everything that happened, I took a lot of time out of work, so they gave my job away. And when I was at work, something happened and I just felt like I did not measure up to what I used to do. And I was like this, and that's not me. And I actually went to Chuck one day and said, I don't know, I think I might be getting depressed, and I'm not that way. And so I said, I don't know, I think so. So before I had gone back to work, I had to take a test, and it wasn't for work, but it was for myself, to make sure that I felt that I was ready to actually go back and to be able to process things. And I was an underwriter. So, I mean, I had numbers, I had people's lives in my hands, buying a house and things like that. So before I took that test, someone had told me, oh, I took that test before, it starts out easy and then it gets harder. Well, I started taking the test and it was hard. And I got choked up and I started crying. I was like, oh my God, somebody told me it gets harder and it's hard now. And I don't know. I don't know if I can do this. So I took a break. But anyway, at the end of the test, and I psyched myself out and I did better. But at the end of the test, the person who gave it to me talked to Chuck and said, listen, if she has this problem again, there is someone that you can go to, and here is her business card. And so she is a speech pathologist as well, but she did life coaching and health coaching too, just for brain injury patients. And so I ended up calling her, and it really,
Brenda?
Yes, and she couldn't be here tonight. And so I did want to mention the fact that, you know, there are people out there, she's a speech pathologist as well. There are people out there so that we don't have to succumb to, like you said, oh, in a year, that's it. You don't have to succumb to that. You just don't. And so I used her twice, and I was very happy that I did. She also does like meditation and motivation and yoga. And it is, and it's like Jenna, they're specifically for brain patients, and the patience that they have is just amazing. And you never feel small. And so I did want to mention the fact that that's what I did, because I did go back to work a little early. And I felt overwhelmed, and it helped me. And now, you know, I'm just me, and that's it. And it's
you actually just addressed you addressed one of the biggest assumptions in our community inadvertently, and that's that we're supposed to be strong. And I don't have better words than to say that that's baloney. No one says that we're supposed to be strong. We're supposed to be human, and everything we feel is okay. It's our feelings are valid, and all of them are valid. One of the things that I personally struggle with is helping make sure people just don't go through it alone. I literally, Dawn, you and I laughed about this once. I give out my cell phone number. It hasn't bitten me in the butt yet. But that's because no one should have to be looking for a Brenda. You can just ask, you know. Another one that I'd like to talk about is this idea, the assumption is out in the community that you're not supposed to talk about it, which is, I'm wondering.
So can I just interject one quick thing at what you the last thing you said, which is probably the most powerful thing about support groups. And and I, you know, I go a few times a year to support group, but it's more powerful for patients and families to be talking to patients and families, because you've been through it. I've been through it 5,000 times with people, but I haven't been through it. And there's a very big difference. And that's true with a lot of different diseases, but I find with aneurysms in particular, it's exceedingly powerful for families and patients to be talking to families and patients, and not in a negative way or a bashing way. That's why it's support. And sometimes just by getting to know each other, they're doing things for each other that I can't do. And it's very gratifying to see that. Pardon me for interrupting. You just made me think.
I'm so glad you did, and that's what this is. Go ahead, Dawn.
Can I add to that?
Yeah.
I never thought I would go to a meeting, and I did, and it was the best thing I did. And the friends that I've met, it's amazing, and we all have something in common. It is great, and we support the Brain Aneurysm Foundation for all that they do, because they've done so much for people like me. So I just wanted to say that.
And I also just want to kind of tag on to some of the things we were saying before too. It's like, you know, we talk about assumptions and brain injury, and for all intents and purposes, right, we put brain aneurysm in the brain injury category, is talked about in the community as the invisible injury, right? And that's because, just like you're saying, Dawn, folks say, oh, you look great. Okay, well, it's not helpful. It's nice to hear that I look good, but I'm struggling underneath. And I think that is what is lacking in the community, is that next level support that helps you kind of move past the things that are invisible, which is the cognitive fatigue, which is the depression that comes along with it, which is that struggle to get back to kind of feeling like yourself again, because you look fine and you're out in a circle of your peers and they're all having a fast track conversation that you just can't keep up with because your brain is now tired. And that is it's a thing that you struggle with, that you can't share and you can't show. And I think, and that is the power of things like support groups, is knowing like, oh, this is normal. It's sort of normalizing that feeling, and finding the groups and also the clinicians and the specialists out there that kind of help carry that through, for sure. And I you know, I just had to jump in that invisible injury piece is so powerful. And that is one of the assumptions. It's like, you survive surgery and you're walking, looks good to me. And that takes away a little bit from how much survivors struggle in really meaningful and powerful ways.
Yeah, and it's exactly, and thank you for that, Jenna, really. But it's exactly what I meant when I said that there's this idea that we aren't, like, the royal we don't talk about it. And so just to kind of come full circle on the idea of support groups here, go, because they talk about it. And not only do they talk about it, they talk about everything. One of my favorite things we started doing years ago with my mentor, actually, who just passed, she was amazing. She thought what we should do is, we have so many people coming with their support. So in other words, it might be a Dawn and Chuck, or it might be a son and daughter, et cetera, et cetera. What we did probably 3 times a year was to separate them. And it was a wonderful opportunity to, you know, if you're the caregiver, to just, you know, talk your part of that talk and not have to have your care recipient there. You might be having a really challenging time with them, and vice versa. It is extraordinarily hard to be taken care of. I think that as the firstborn of a giant family, I probably would be a terrible patient. Jenna, and you too, Chris, if you wouldn't mind answering this one, I think it might be one of my last questions. What are the assumptions within your arena, I'll just make it very broad, that you wish would go away?
Oh, there are just so many. You know, I think in terms of recovery, it's there's an outdated sort of model, and Chris touched on this in terms of the research that we have and how folks do. There's an outdated understanding, and folks still hear this in the hospital, that like what you get at 6 months or a year, that's it. That's as good as you're going to get. And a lot of that, I think, comes from old stroke literature and research, but is sort of populated across a range of brain injury. And I think it's the idea that you have your best shot early on, and after that, you're not going to continue to get better. And so I think for individuals and the community at large to understand that recovery goes on. for years and forever. You know, we tell people it's like we're all changing as we age, hopefully getting better at some things, and so that the trajectory is always up. And so knowing that the recovery can continue, I would say that's a big one on my end.
I'm going to ask that all of us on this panel today put that bee in our bonnets, because it's my pet peeve for sure. Thank you for saying it again.
So
Chris, what about you?
I would chime in that one of the things I really wish would go away was and it's impossible, but the influence of insurance companies on dictating rehab. And and it has taken sometimes a battle, but I've even had the situation where someone with a very bad hemorrhage from an aneurysm in the ICU goes to the floor and then is ready to leave the hospital. And as Dawn said, not getting the medical stuff, but not quite ready for the rehab, meaning they're not interactive enough yet. And I've actually arranged it with a few insurers to put that person in a situation, sometimes even a nursing home for 2 months, then in a rehab. And they've done better because at that point they're ready for rehab. The problem is the way the system's set up, they leave the hospital, they go to rehab. Well, if they're not interactive during their rehab time, the rehab doesn't do anything. However, 6 to 8 weeks later, when they're more interactive, they can actually use the rehab. But much of it is dictated by insurance companies, and you know, Jenna will do her evaluation, physical therapy will do their evaluation, and they are dictated by insurance companies to fill out forms which say who can go. I mean, they fill out how the patient is doing at that moment. And as you all know, this is a dynamic process, and how they're doing at that moment could be very different than how they're doing 2 weeks later. But based on how those boxes are filled out that moment, that dictates then the next 6 weeks of rehab or their situation. So that's somewhat of a frustrating framework to work within. The physician has no say in this anymore. You know, 30 years ago, the physician could say, look, this person, I know how they look, but they really need rehab, not a skilled nursing facility. And they would go to rehab. Nowadays, you have no say in that, which is a bit frustrating for families, patients, physicians, everybody. But we've tried to work with people to help with that kind of thing. But it's hard with the system the way it's set up right now.
I don't know if this is related or not. And I'm curious. I know at UCSF, they start rehab while you're in ICU. And I know that's happening in a lot of different facilities. I'm curious, does that compound that? Does that make insurance companies think they're more ready than they are, or does it actually help?
It's an excellent question. I don't know if Jenna knows the answer. I do not know the answer to that, nor do I know if there's data to support early rehab efforts like that. I think people are trying to collect that data now. It gets so nebulous. It's hard. It's not hard science. Yeah. And again, what we mentioned early on, there's a great heterogeneity, a great range of people's response. So trying to get that all into a nice little study with standard error bars is very difficult. But I've seen that be effective, and I'm not adverse to it. My motto is whatever works. You know, like
I like your motto.
People come in and they tell me they want to try some therapy I know nothing about. If it helps them, that's a good thing. You know, and sometimes I learn about a therapy I didn't know about. You know, so those are things that influence it as well.
That's my motto when Dawn and I were doing this. I'm like, what do you want to do? It sounds fun. Let's do it.
Yeah, you know, in sort of the acute hospital world, there is we do early often rehab in the way that makes sense for the patient. And as far as I know, it doesn't compound things, but what does happen is sometimes that does check those boxes, which show that someone either isn't doing well enough to go to acute rehab, and even if we think they should, or occasionally someone will do so well that insurance goes, they don't need rehab. And that's a problem too. And as a speech therapist, because what that generally looks like is someone is up and starts walking the hallways, even though they might have a severe cognitive or language deficit, and insurance goes, they don't need rehab. So I wouldn't say it compounds it, but it's all a little bit of a game in terms of what we're doing and how we're documenting it. And rehab clinicians, we're very sensitive to that, because you always want to show progress, but sometimes you're scared to show too much progress. And it is this big nebulous insurance driven situation. And that was partly what drove me, you know, if you look at my business, my Fit to Function my sort of tagline is better than good enough, because what insurance says is good enough, see you later. And I want individuals to know that recovery is more than just being good enough. It's better than that. It's your standard. It's getting you back to you.
Jenna, I think that you and I were meant to meet, by the way. We have a very, very similar approach to people.
Well, you're stuck with me now. So
yep, absolutely. Dawn, you are the guest of honor, and I want you to have the last word. I will first, I guess, plug away. Please go on to taafonline.org, read our magazine, follow us and all that stuff. But most importantly, I want to thank Dr. Ogilvy. I want to thank Jenna. I want to thank you, Dawn, and thank Chuck for letting us borrow you for so long. It is integral to the way that the Aneurysm and AVM Foundation does what we do to make sure that we are good listeners, that we are telling the good stories and fighting the good fight. And Dawn, from the moment that you and I have met, I wanted to be part of your story. And I think that people tonight definitely didn't hear all of the assumptions. That would take us forever, a whole lifetime. But I think that we have helped people, and I hope that they've enjoyed listening to us. I am so grateful for all of you. Dawn, tell us, what would you like to say?
I would like to say that as a person myself who always loved life, all of a sudden got this giant fusiform aneurysm, which was 31 millimeters and whatever arteries and all that stuff. And living the way, you know, I had no idea if I was going to get through it. And it took me a long time. I do have drive, I have to say, you know, but I wanted to push myself. I had a good caregiver, my husband. If he didn't research all that stuff, I don't know what would have happened to me. You know, my family is also very supportive. So I want to thank everyone for that support, because, you know, if I didn't have that, I would be different. And I am a different person from before. I do have things, doesn't matter. I work around them. I do what I can. And like Jenna, I love working out. It makes you feel so confident in yourself. So anyone out there, get going. You can do it. And it feels great. And thank you so much. And this night meant so much to me. I just want to say thank you. Thank you, Jenna. Thank you, Chris, Dr. Ogilvy. I really respect all of you. Thank you very much.
On that note, I want to thank everyone who's been here. We're going to try not to cry on our way out. If my guests can still just hang for a moment, but we'll say goodbye to everyone else.